Halo?
Pagi Bu Ayun.
Halo Bu Diar, bisa mendengar?
Iya bisa. Ini Prof Maznah sudah masuk, tinggal nunggu Pak Budi, Pak Dekan.
Saya sudah masuk, Mbak.
Oh ya, sudah ya Pak. Berarti bisa kita mulai.
Silahkan.
Oke, kita mulai aja ya kalau gitu Bapak Ibu dan teman-teman semuanya. Ya, good morning everyone. Assalamualaikum warahmatullahi wabarakatuh. So first of all, let's thank to Allah Subhanahu wa Taala who has been giving us mercy and guidance so we can gather and attend this event even though it's online in a good condition. My name is Diar. I'm one of the lecturer in Health Policy and Administration Unit, Faculty of Public Health, Universitas Diponegoro, and I'll be conducting today's guest lecture as the moderator. First, thank you for Professor Dr. Maznah Dahlui for sparing your time to be a guest lecturer for our students in Faculty of Public Health. And also thank you for our Dean, Dr. Budiono, and also the Head of Health Policy and Administration Unit, Dr. Ayun Sriatmi, for attending this meeting today. And last but not least, thank you for all the lecturers, colleagues, and also students from Faculty of Public Health for attending this guest lecture. We hope we all can get something new to learn and actively participate, especially in the discussion session later. Okay, the first agenda is the opening speech from Dr. Budiono SKM MKes as the Dean of Faculty of Public Health, University Diponegoro. Dr. Budiono, the time is yours.
Thank you very much, Ms. Diar. Bismillahirrahmanirrahim. Honorable Professor Dr. Maznah Dahlui from Faculty of Medicine, University of Malaya, Malaysia. Dear Dr. Ayun Sriatmi and the college, and also the participants. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Okay, thank you very much. Alhamdulillahirabbil alamin. We are in health condition, I think, in good condition, and safe from the pandemic, of course. And thank you for joining this virtual meeting with the team, visiting professor, with the guest lecturer from the Malaysia, Professor Dr. Maznah Dahlui. We take the topic about the COVID-19 situation in Malaysia. So we hope this meeting on this seminar will have some experience from the neighbor country, especially Malaysia, for the managing the case of the COVID-19, and especially because this event initiated by the unit or department of the administration and policy. So the financing is important for us to maintain or to overcome this COVID-19 situation. So we hope Professor Dr. Maznah Dahlui has many experience and knowledge in field of health financing, and what is the strategy that's implemented, especially by Malaysia government to overcome this pandemic. I hope the participation will active in this discussion and enjoy this webinar or this meeting. So thank you very much for joining this meeting Professor Dr. Maznah Dahlui, and we can extend or expand this collaboration, not for just the guest lecture. I think we can conduct the research or joint publication, and also maybe some activities in international program, because our university push us to collaborate with the foreign university to conduct some research or community service, or maybe also internship in our faculty, and also we can conduct the benchmark to the other universities in abroad. Thank you very much. With your permission and Allah Subhanahu wa Ta'ala, this event I open officially. Bismillahirrahmanirrahim. Thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam. Okay, thank you, Dr. Budiono, for opening this event. Well, we also hope that we can, prolong this collaboration with Professor Maznah, not only as the guest lecturer, but also for future program with University of Malaya. Okay, thank you. Then, without further ado, let's move on to the main event, the guest lecture by Professor Dr. Maznah Dahlui. But first, let me read a short biography of Professor Dr. Maznah Dahlui. So, Professor Dr. Maznah Dahlui is a public health medicine specialist in Health Policy Management Unit, Department of Social and Preventive Medicine, Faculty of Medicine, University of Malaya. Her specialty is health economics. According also is in line with today's topic, with a major interest in the evaluation of health programs. She had performed many economic evaluation on disease management and health programs, also working with various ministries and researchers in the country as well as international. So actually, I've known Professor Maznah since my university days, because when I was a student in Universitas Airlangga, she was also the visiting professor in Universitas Airlangga. So, and I also, attend some of her lecture before. So, well, because I have those experience and I want to share it now, because now I'm working in Universitas Diponegoro. That's why I asked Professor Maznah to attend as a guest lecturer also in Universitas Diponegoro. I think that's enough for the introduction. Today's topic is the COVID-19 situation in Malaysia, case management and financing strategies. And I think it's going to be interesting to learn about, the strategies in other countries, especially in Malaysia, and also especially for students in health policy and administration. And we will play the video for the explanation from Professor Maznah. And if you have any question, please raise your hand later on the discussion session, or just write down your question in the chat box. And also, please don't be afraid to ask, because you can also ask in Indonesia if you are not that confident with your English. But well, I strongly, Professor Maznah also can understand about the question. So I hope we all can, participate actively in today's session. Okay, so I'll play the video. Wait. Okay.
Assalamualaikum warahmatullahi wabarakatuh. Hello everyone. Thank you for attending to this presentation. My name is Professor Dr. Maznah Dahlui. I am from the University of Malaya, Malaysia. I shall be sharing with you on COVID-19 situation in Malaysia and on the case management as well as financing strategies that has been taken up. First of all, I would like to thank the Facultas of Public Health, University of Diponegoro, for inviting me to deliver this guest lecture. I shall be talking about COVID-19, especially the updates in the world as well as in Malaysia, the strategies for control and management of the pandemic COVID-19, the facilitators and challenges faced, the financial implications and financial strategies that have been put in place. I shall also share with you about the vaccine promises. Reached Malaysia in late January and was largely confined to imported cases. Local transmission began to emerge in early March and was linked to a religious gathering by people from various countries. We had the first wave of infection from mid-March to mid-June, and after low cases for several months, in mid-September, cases started to increase and had made the third wave. The number of cases per day had been 2 digits after the second wave in May, with most cases were seen in Selangor and Kuala Lumpur. However, since October, the cases per day averaged to 800 plus, with Sabah recorded the highest, followed by Selangor and Kuala Lumpur. And this occurred especially after Sabah's state election in late September. As of the 21st of October, the total number of cases in Malaysia was 23,804, with 204 deaths. Let us now look at the strategies for control and management. We know that countries have applied various strategies to deal with this pandemic, with many opting for various degrees of lockdowns and physical distancing measures. The success has been variable between countries. Therefore, it is difficult to gauge the success or failure of these measures. Early and strict governmental intervention is a key factor in reducing the spread of COVID-19 cases. In actual situations, the speed of transmission can be changed through many interventions, such as personal protective measures, community-level isolation, and city blockage or lockdowns. From China's experience, various control measures, including the early detection and isolation of individuals with symptoms, traffic restrictions, medical tracking, and entry or exit screening, have prevented the further spread of COVID-19. Test to screen, diagnosis followed by treatment with isolation are to reduce the morbidity and mortality, while track, as in contact tracing, followed by quarantine, are important to prevent the spread of infection. Various health interventions, either pharmaco or non-pharmaco, and other strategies can work either in isolation or by combination, as shown in the diagram. As for Malaysia, various policies and directives have been implemented under legal protection of the Act 342. This is the Prevention and Control of Infectious Diseases, 1988 and was amended in 2006. The Movement Control Order, or MCO, was implemented from the 18th of March to 3rd May, whereby all activities had been stopped and total lockdown was practiced. Movement Control Order, or MCO, was then followed by Control or Conditional MCO, where there was easing of restrictions from the 4th of May to 9th June. This was subsequently followed by Recovery MCO, during which time almost all restrictions had been removed, and it was effective from the 10th of June until the end of the year. In between, TEMCO or Targeted MCO for areas with clusters or areas identified as red zones, whereby people in that area will be under conditional MCO. The Army and Police are the government agencies responsible that the activities for all MCO policies are implemented, and they are governed by the Police Act 1967. As for the activities allowed during MCO, in the first MCO, all sectors were closed except for essential services such as hospitals, clinics, groceries, either big or small, food premises. However, dining in was not allowed, telecommunication sectors, bank services, and etc. All borders were closed for international as well as for local, and interstate movement was very restricted. Local movements were limited to 10 kilometers from home, while all gatherings were banned, including Friday prayers. And at all times, hand washing, wearing face masks, especially at the public places, and keeping social distance were enforced. As for the activities during CMCO, important manufacture and industries were allowed to open, but for limited time, and there were controlled number of workers at a particular time. School had continued to be closed, and during this period, the online classes had started. Work from home continued for most sectors, including those with counter services, and borders were closed to foreigners, while interstate movement would need police permission. Quarantine for those returned from overseas had been put in place. However, during this time, they were supposed to be quarantined only at home for 14 days. And sanitation of public places had been expanded, especially in the public transports. In the third phase of MCO, or Recovery MCO, which will be reviewed at the end of the year, schools can be opened, but only for half-class occupation, and students are to bring their own meals. Small group gatherings has been allowed, but not more than 20 people in a normal size house. Gatherings up to 250 people for weddings or important events are also allowed, but need to practice 1 meter distance, wearing face masks all the time, and the host is expected to provide hand sanitizers to the guests. During this RMCO, new directives are being added. On the 24th of July, the directive on all incoming travelers, either Malaysians or expatriates, are to undergo 14 days mandatory quarantine at government-designated facilities and to be tested using PCR upon arrival, since many people had not complied to home quarantine that was directed earlier. While home surveillance is practiced for those making interstate movement from the red zones. If from the beginning of the epidemic, people had only been advised to wear face masks, starting 1st of August, face masks had been made compulsory. A fine of 1,000 ringgit is issued for non-compliance, while premises allowing people without masks to enter will be fined 5,000 ringgit. And from the 1st of September, travel ban had been applied for traveling to or from countries with more than 150,000 COVID-19 cases. The following are the list of countries which travel is banned. Initially, there were 22, and over the months, more countries had been added to the list. The first CMCO was held at one of the districts in Kedah in July when a cluster was initiated by a food premise owner who came back from overseas but did not comply to home quarantine. Thereafter, several districts had been put under TEMCO when more clusters had emerged consequent to this. This was the reason why the home quarantine could not be relied upon and the government had to make compulsory for institution quarantine. In mid-October, when cases in Sabah was overwhelmed, the whole state of Sabah had been put under CMCO, which was followed by Selangor, Kuala Lumpur and Putrajaya, and they are all now still under CMCO. In the first 6 months of the pandemic, Malaysia had been listed as one of the countries able to flatten the epidemic curve of COVID-19 through the various interventions. The success that Malaysia experienced in controlling the epidemic was due to many factors, although we were not free from having to face all the challenges. There are many factors that facilitate the control of COVID-19 in Malaysia. First, policies only come from the central government. The Ministry of Health and the National Security Council had been regularly announced on the policies of the government. The state administrative government followed the directive without amendments or addition. The official directives are very clear and repeatedly emphasized, especially with regards to the SOP of COVID-19, which must be strictly adhered to, and non-compliance are considered as offence with penalty, while false information and rumor spreaders are punished. Second, the existing healthcare delivery system is very established and has some space to accommodate the increase in disease loads of the pandemic. Before March 2020, 40 out of 147 public hospitals all over the country had been gazetted as COVID-19 hospitals. Plus, a university hospital in Kuala Lumpur had been added as one of the COVID-19 hospital. And on May the 7th, more public hospitals were added in order to cater for the second and subsequent wave. A provisional hospital was also set up in a convention center to be used as a quarantine and treatment center for low-risk patients, with 164 beds had been prepared to cater for confirmed cases with or without symptoms of COVID-19. At any day, only 36% of the total hospital capacity had been utilized to cater for COVID-19 patients. There was also a very fast actions taken to mobilize PPE and ventilators to the hospitals. Within the first week of March, the Prime Minister of Malaysia had announced financial allocation of 259 million to all the general hospitals to purchase PPE, ventilators and drugs to treat COVID-19. In addition, 500 million was given to Ministry of Health for the same purpose, plus to increase screening for the infection with the aim to achieve 35,000 tests per day. A further 100 million had also been given to recruit more contract health personnel for preventive measures. Fourth, technology support. National e-COVID database system was set up to electronically store all contact tracing and clinical data on COVID-19 patients. The Ministry of Health had also deployed digital contact tracing apps, or called MySejahtera, for attendees at public places such as at food premises and shopping outlets to register. These applications, alongside with clear and implementable data privacy laws, had encouraged high user adoption. In addition to all these, financial assistance to the people for their welfare and economic stimulus to the small and some big companies, manufacturers, industries, even the taxi and hailing businesses were given in order to ease the financial burden consequent to lockdowns. In addition, various sectors had responded to support COVID-19 control. For example, the university had opened up several wards at their hospital to treat COVID-19 cases, while private hospitals had offered to take over and treat public non-COVID-19 patients at public charges. There was good support of the people to the frontliners and cooperation from all levels of populations to lockdowns and SOP. Solidarity can be clearly seen with the slogan, "Kita jaga kita," or "We take care of ourselves." While communications to disseminate the information on the epidemic situation and the needed interventions is made daily by the authorities, had made the people feel secure and confident. Prime Minister himself had declared the emergency, reassured and had promised to protect the people, that the government will provide financial assistance to them. People are continuously informed on COVID-19 situations in Malaysia, and the announcement is only made by the Director General of Health himself, not missing a single day. While policy implementation and enforcement are only upon the directive by the Chair of the National Security Council. The media has been playing an important role in assisting the authority in getting the cooperation from the public to follow the directive and advices by the authorities, besides putting the people in the light of what is happening. They continuously get the experts from various related fields for their opinions on strategies and their comments on the government efforts in handling COVID-19 crisis. The control of COVID-19 epidemic is not all smooth and easy. As in any other crisis, the nation is faced with several challenges. The high number of infection, with uncertainty to manage the infection during the early stage of the epidemic, and with substantial number of deaths within a short time, had caused stress and fatigue to the healthcare workers. There is also issue of high-risk exposure to the frontliners, especially to the healthcare workers, and disruptions to supply chains of healthcare products, cause shortage, which may lead to frauds. It's unfortunate that politicians can somehow override the system or the policy that they had consented and preached. When everyone is anxious of the infection, the ruling party had exercised election to select a new government in Sabah. The election campaigns had not followed the SOP, with the leaders not wearing face masks, not registering their whereabouts among the crowd, and failed in maintaining social distance. On the other hand, the common people are expected to comply to the directive and will be punished if they do not follow the SOP. And because of the election campaign and voting exercise in Sabah, COVID-19 cases had increased from less than 2 digits over the months of July to mid-September to more than 3 times, which gave rise to the third wave of infection. Movement control order had been exercised again in Sabah and in 3 capital cities of the peninsula. So what and how does COVID-19 pandemic affected the economy? COVID-19 could affect the global economy in 3 main ways, which are by directly affecting production, by creating supply chain and market disruption, and by its financial impact on firms and financial markets. However, a great deal depends on the public's reaction. With regards to impacts of COVID-19 to healthcare spending, it was projected that healthcare spending across the world's 60 biggest economies will fall by 1.1% in US term dollars in 2020. This is because the battle against the novel coronavirus has led to a sharp drop in spending on other conditions, with non-urgent care cancelled and patients avoiding hospitals and clinics. Not only the morbidity and mortality of other diseases like NCDs and cancers will increase, but the cost implications of these diseases to the healthcare system would be much bigger than before the pandemic. Non-health interventions, such as the lockdowns, had turned the GDP growth to be negative in all over the world. COVID-19 adds to the list of disease burden to the healthcare system and caused huge healthcare expenditure from direct cost of treatment, screening, contact tracing, and quarantine. This economic loss is made worse by the aversion behaviors that need to be put in place, i.e. the lockdowns, as well as to maintain the social distance. All the strategies for control would need extra budget by the government, who would also need to financially assist the people affected by unemployment and income loss. As you could see from the diagram, there are short-run effects as well as long-run effects. The immediate and direct potential impact of COVID-19 has already resulted in thousands of lives lost and significant incremental costs to the healthcare system. According to a paper by Berkeley economists, if 50% of the world is infected, 1% of the world, which consists of 76 million of people, will die. And this assumption is based on the available critical care beds and a 2% case fatality rate. A strong policy response includes measures that both should delay and reduce the peak number of new cases to prevent the healthcare system from being overrun. Ongoing research and for more effective treatment and a possible vaccine do not solve the immediate problems of system capacity. Therefore, much needs to be invested with regards to improving or expanding the healthcare system of a particular country. The ability of a country to put the epidemic under control depends on so many factors. The capacity of the healthcare system should be as such that it is resilient to crises such as this pandemic. The table shows the capacity of 5 selected countries in managing COVID-19. It is expected that countries with high GDP per capita income would have good investment on the healthcare system. However, if there is no clear and strict control of the epidemic by the leaderships and no cooperation from the people, cases will escalate as is seen in the United States. As for the fatality rate, it is contributed not only by the ability of the hospitals to handle severe cases, but is also due to age and comorbidity factors. Singapore is known to have good health interventions to control the prevalence of non-communicable diseases. Thus, although the proportion of elderly is as of the developed country, the fatality from COVID-19 is small relative to the number of infection. The number of people screened is important, and the volume depends on how much a country could allocate for screening. Indonesia should have screened more people since the positivity rate is twice and 3 times than other countries, and in general should invest more on her healthcare system. Since COVID-19, which is caused by SARS-CoV-2 infection, which mainly affecting the respiratory system, was just discovered in late 2019, the pathophysiology is still being discovered, and treatment is by modifying the treatment protocol for SARS and MERS-CoV infections. Resource utilization and cost of severe infection is 3 times the cost of mild infection due to ICU stay and use of ventilators. In the US, the cost of treatment of COVID-19 without complications, as for treatment of pneumonia, is USD 9,763, while those with complications cost USD 20,292. These findings is according to Kaiser Family Foundation. In China, the mean cost per episode without pre-existing disease is USD 6,827, with the highest mean cost for drug acquisition. Estimated USD 0.49 billion for clinical management had been taken up just to treat for COVID-19. According to the Ministry of Health Malaysia, Malaysia spends approximately 18,270 ringgit Malaysia to treat one severely sick COVID-19 patient for an average hospital admission period of 3 weeks. This is very underestimated cost since it used the case mix for severe respiratory infections, when it is known that the severe forms of COVID-19 usually require more than a week's stay at ICU and the use of ventilator support. Preliminary findings from a cost study by researchers estimated the average cost to manage severe COVID-19 patient is 30,000 for just a week's stay at the ICU, while the cost to isolate and treat mild cases is 20,000 ringgit Malaysia for the 2 weeks admission. While in 2019, the Parliament of Malaysia had approved a budget of USD 5 billion to combat NCD in 2020, COVID-19 in 2020 had already used up approximately 600 million of the budget just for hospital management and not including the cost of screening, surveillance, and other health interventions due to COVID-19. Thus, there is no doubt that the economic impacts of COVID-19 is adding to the already stretched economy of Malaysia. As for the cost of tests, in United States, the cost for COVID-19 PCR test is 100 USD, but some insurers had charged up to 2,315 USD. And because of that, FDA had authorized emergency use to Abbott Laboratories for a new test that could detect SARS-CoV-2 viral protein or antigen, which cost only 5 USD. And this test does not require specialized laboratory equipment, and the test can be done in 15 minutes. Singapore's cost per test of PCR is 200 Sing dollar, and this is covered by the government for all the people. As for Malaysia, the government had announced that the cost of various tests for COVID-19 for Malaysian at public laboratories is 30, 50 and 200 ringgit for antibody, antigen test kits and PCR tests respectively. These are subsidized costs, but those considered as person under investigation are not required to pay, while the private lab or hospital charges is in the range of 300 to 500 ringgit Malaysia. If we use the actual cost of his CV PCR test cost or the test for hepatitis C virus to estimate the amount that we spend on COVID-19 testing and applying the total number of testing by MOH up to 8th of October, which was 1,681,809,000. The total amount is 467.9 million ringgit. This causes a huge financial burden to the healthcare system. The cost of quarantine is also expensive. The government is spending roughly ringgit Malaysia 4,700 per person to be quarantined, either Malaysian or expatriates returning to the country. The cost is 2,100 for accommodation and 2,600 for operational costs. Malaysian does not need to pay for the operational costs or for the accommodation, but non-Malaysian would need to pay for the accommodation at a hotel or government-provided rooms while the government absorbs the operational costs. As for the operational costs, the government had spent roughly 115.9 million on designated COVID-19 quarantine centers across the country, of which 49.6 million was for hotels that were used as temporary quarantine centers for the returnees. So let us now look at what are the vaccine promises. While vaccine development can take years, researchers are not actually starting from scratch to develop a COVID-19 vaccine. Past research on SARS and MERS-CoV vaccine has identified potential approaches. There are about 200 pharmaceutical companies, including research centers and universities, engaged in developing vaccine for COVID-19. However, there is a concern pertaining to the access to the vaccines once they are developed. Therefore, in September 2020, the World Health Organization had come up with a special plan on developing, purchase and distribution of COVID-19 vaccine to ensure that all countries can get access to it. The access plan, which is called COVAX, is coordinated by Gavi, which is International Vaccine Alliance, together with Coalition for Epidemic Preparedness and the World Health Organization. COVAX provides a platform that will support the research, development, and manufacturing of a wide range of COVID-19 candidates, and it aims to deliver 2 billion doses of safe and effective vaccines by the end of 2021. A total of 172 countries have already engaged in discussion to potentially join COVAX, and they are 80 higher income countries, which will be using their own national budgets, while 92 low and middle income countries will be receiving some financial support from WHO through COVAX Advanced Market Commitment or AMC. COVAX AMC belongs to the World Bank, is a financing instrument that aims to support the participation of 92 lower and middle income countries, including Maldives. There are 9 candidate vaccines that are currently being evaluated for inclusion in the COVAX facility, and they are shown in the diagram. 2 already in phase 3, while 7 are in either preclinical or phase 1 or 2. It is absolutely necessary for Malaysia to have its own plan ready concerning the procurement, deployment at scale, and sustainability of its COVID-19 vaccine supply. However, COVAX Vaccine Access Plan for COVID-19 requires upfront payments from self-financing participant countries because COVAX needs US $18.1 billion in order to cover for the manufacturing costs and to procure about 950 million doses of vaccines and deliver to the low and to the middle income countries. Malaysia might not be eligible for COVAX AMC or the aids from the World Bank and thus would need to pay using the taxpayer money. Thus, Ringgit Malaysia 545 million had to be paid by the government of Malaysia as advance money in order to secure the vaccine for 6.4 million people, which is approximately 20% of Malaysian, for a 2-dose regimen at Ringgit Malaysia 44 or USD 10.55 per dose. This means that the Malaysian government needs to add on some budget to the already high costs on healthcare spending by the Ministry of Health and the people at large. The Global Vaccine Plan, or COVAX, may not be able to meet the needs of the population of the respective countries. Therefore, the World Health Organization does not restrict the participating countries to pursue with other approaches to obtain COVID-19 vaccine, such as bilateral agreements with countries that develop the vaccine. Malaysia had signed a letter of intent with Russian embassy to obtain more information on their Sputnik V vaccine, and Cuban embassy to express a desire to collaborate with the Finlay Vaccine Institute and the Center of Genetic Engineering Biotech in Cuba. In addition, Malaysia had also expressed its intention to work with the Chinese government through biotechnology Sinopharm and pharmaceutical companies Sinovac Biotech to secure a COVID-19 vaccine. However, the cost per dose of the China-owned vaccine was estimated to be 7 times more expensive than COVAX Vaccine Scheme, which is $72.50 per dose. Nevertheless, every country is still looking for means to get vaccine soon as possible so that their people are protected from COVID-19 infection. As a conclusion, it is important to ensure that there is balance between implementation of the various health interventions for control of the pandemic and the economic situations of the people and country, especially pertaining to the lockdowns. The government is obliged to financially assist the people so that life can go on and provide support to the business sectors in any form so as to make sure that people will continue to have jobs during and after the pandemic. Investment for a comprehensive and well-prepared healthcare system should be established. Equal focus should be given to preventive health as well as curative care. The healthcare workforce should be strengthened in terms of adequate number of all categories of health personnel, and appropriate training should be given to them. Information technology, or IT, is an important support to healthcare service delivery, and innovations for access to the healthcare services should be developed to achieve and sustain universal health coverage. As for COVID-19, strategies have to be made to ensure that the right volume of screening is conducted and targeting the at-risk population, followed by treatment and care support. A vaccine to prevent COVID-19 is the best hope for ending the pandemic. But in the meantime, strong leaderships and fullest cooperation of the people to follow the SOP are necessary to break the chain of infection. With that, I've completed my lecture. I hope that you understood. If there's any questions, you're welcome to ask. Terima kasih. Hashtag kita jaga kita. Stay safe.
Okay, so that was the presentation from Professor Maznah. And if you have any question, or maybe there is something that interesting about from the presentation, you can ask directly to Professor Maznah by raising your hand, and I will allow you to ask or write it down on the chat room. While waiting, we have a question from Bu Ayun, Dr. Ayun Sriatmi, in the chat room. So, Professor Maznah, has the implementation of Bu Ayun, do you want to read it by yourself or? Hello, Bu Ayun. I cannot hear your voice. Okay, so I think I'll read it, the question. So from Bu Ayun Sriatmi, has the implementation of the lockdown policy in Malaysia also received strong resistance from the community, especially the middle to lower economic community with daily income? The reason is because they cannot work and earn money for daily living and cannot freely interact socially with other people. So how will the Malaysian government policy resolve the situation of rejection? Could providing cash assistance overcome this resistance or not? Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Yeah, again, I would like to thank University of Diponegoro for inviting me to give this guest lecture. And back to the questions by Ibu Ayun. I think that is a good question. Been asked so many times with regards to that questions. Fortunately, the people of Malaysia is how to say. I wouldn't say that we are kind, but then I would say that we are so-called menurut perintah. To be frank, there is no group of any resistance that we have witnessed so far. Okay, unlike in UK, and if you could observe, actually in Malaysia, even with regards to politics, also we are not. We wouldn't do demonstration, or very rare, except for the 1998 when there was a big reformation or revolution took place. But otherwise, there's totally no resistance from the public. And I guess because in the first 6 months, there was quite a good financial assistance from the government, and as well as from the NGOs. Yeah, almost every people, those with income less than 3,000, or even those income between 3,000 to 6,000 ringgit Malaysia, they get financial assistance from the government, be it single or family. Even my daughter, she gets allowance for not. Even though my daughter is working, but because she's single and her income is less than 3,000 ringgit Malaysia, she got about 500 ringgit for 2 months. So that means in total she got about 1,000 ringgit. So imagine if she can get it, what more for those people below 40%. We call that as B40. So B40 are those people whose income, family household is less than 6,000 ringgit. And not only that, the total lockdown was when nobody can open up their business, okay, except for, like I said just now, essential services like the supermarkets which sell groceries, or even food outlets. They are allowed to sell their food, but it's only for pack, okay, for takeaway, or for the Grab and for the Grab food people to deliver the foods to the homes. But currently, we know that the situation in Malaysia is quite worrying, whereby we now within the last 3 weeks we had double the total number of cases. Okay, because when I prepared this video, it was like 10 days ago, and you could see that it's only about 11,000 total cases. But over the 2 weeks, over the last 10 days, we had 26,000 cases, and majority of these cases actually is from Sabah. So in Sabah now, and in the past 3 weeks, they have been on total lockdown. But because of the people who went to vote, or people who attended the election campaign in Sabah in late September and early October, when they come back to, most of them, they are from Selangor or the Klang Valley. Klang Valley would include Selangor, Putrajaya, as well as Kuala Lumpur. So they come back and they brought in cases from Sabah. Positive cases actually mostly from Sabah. And because of that, we have to be on lockdown, but different from Sabah, which is total lockdown. In Kuala Lumpur now, where I'm staying, it is CMCO, conditional lockdown. Okay, that means I can still move about, and of course, because I'm the frontliner, because I'm working in the hospital, but also other people who needs to go to work, they can go to work, but of course with permission. We bring our work pass wherever we go, but we are not allowed to be doing social gatherings or doing shopping, for example. But not sure how long this will last. I mean, so far so good. There's no resistance, but I think if there is going to be another total lockdown, maybe some people would resist, especially those in the business sectors.
Okay, thank you, Professor Maznah. Bu Ayun, do you have any, addition or something to say? Hello, Bu Ayun. I still cannot hear your voice. Okay, I think there is some connection problem with Bu Ayun, so thank you for the explanation, Professor Maznah. Well, I think it's really different from Malaysia and Indonesia, because here we have a really strong rejection, and people are, not everyone is following up with the protocol or the SOP. And here I see Khairunisa. Do you want to ask question? Bahasa Indonesia nggak apa-apa, Nisa. Hello? No?
Kalau tidak.
Okay. Okay, so anything else from the other students? I think we saw a lot of students here, but, well, is there any question for Professor Maznah? You can raise hand or just, okay, Nabila Ayu Zahra, you can unmute your microphone and ask.
Yes. Assalamualaikum warahmatullahi wabarakatuh. Yes, my name is Nabila Ayu Azhara. I want to ask some question for Prof. Maznah. Like Prof. Maznah said before, that Indonesia should screen more people to tracing the COVID-19 cases. But as we know, the Indonesian is very large country and that have many islands and have a large population too. So there are still many people who only carry out screening if they already feel the symptoms of COVID-19. Even though currently there are many cases of COVID-19 that do not show symptoms, but it turns out that they have been infected. What I want to ask, how is the Malaysian government screening system so that people who don't show symptom can be tracked and immediately given treatment? And maybe there are suggestions for the Indonesian governments to increase COVID-19 screening. Thank you.
Yeah, thank you, Nabila, for the questions. Okay, all right. First, we have to understand the difference between mass screening and targeted screening. We are not like in New Zealand, whereby they do mass screening. They screen all their people. Okay, they can afford to do that because there are not many cases there, and also because it is an island. Okay, and almost no movement between internal and external people to the island of New Zealand. In Malaysia, we practice targeted screening. Targeted screening means that we, of course, other than screening of those contacts, okay. Of course, first we screen those with symptoms. All right, those who comes with symptoms of COVID, they will be tested. But we also test people who come for non-COVID symptoms, like for example, influenza-like illness. I hope you understand the difference between the symptoms of COVID-19 and the symptoms of other influenza-like illness. Okay, and then we will also screen or test people who are with severe acute respiratory illness. Those people who comes to the hospital or to the outpatient having symptoms of respiratory infection will definitely be tested, although there's no history of contact with COVID-19 patient. And also those patients who have been admitted and are due for operation, okay, or any procedure, they will be tested. And all that, irrespective of having the symptoms of COVID, they will also be tested. And with the targeted screening, actually our screening positive rate was only 1%. Sometimes there were 2%, and because of that, the Ministry of Health Malaysia thought that there's no need for us to do mass screening. So it is really basically targeted screening. I think similar should be conducted also in Indonesia, because we have to admit that we definitely couldn't afford mass screening, especially because budget is very limited. Okay, we have to do take out cost-effective implementation or intervention. So in this case, all those patients with symptoms, all those patients with contacts with those confirmed to be positive, okay, they should be tested. But on another note is that not only we have to increase the screening, but when we increase screening, we have to take note on where to put what to do with those positive cases. In Malaysia, we are just like in Thailand, all positive cases are admitted. Okay, before this, when the number was not too high, all positive COVID-19 patients, they are admitted to the hospitals. But now, because of the situation, especially in Sabah, because of the overwhelming number of cases, they only admit the moderate and severe cases, because there are 5 levels that they have categorized. So level 3, 4, and 5, they will be admitted to the hospital, while level 1 and 2, meaning that those without symptoms or those with mild symptoms, they are admitted to the temporary centers, which I had mentioned earlier. We start treatment even with asymptomatic cases. Once you are positive, you will definitely receive the antiviral and antibiotic. And of course, other support care like the nutrition and whatnot. So I'm quite skeptical if Indonesia could afford to do that, meaning admit all positive cases. So this is where needs to educate the people so that maybe those with history of contacts, if they are not be able to be tested, then they should be home quarantine. I hope I answer your questions. So we are in the containment period. Okay, we are still in the containment exercise. If you know about epidemiology, okay, there are containment and mitigation. Okay, so far we are still under containment, but in countries like in Spain or in Italy, they are all in mitigation period, whereby they only treat severe cases. Okay, the asymptomatic and even those who are positive with mild symptoms, they are not being what do you call that? Not being isolated or contained in an institutions. Okay, so I'm not so sure about in Indonesia, but I guess in Indonesia it is more of mitigation, whereby you admit those symptomatics and not so sure whether you admit the moderate or you just treat those who comes with severe symptoms. I think maybe Ibu Dia can briefly describe what is the situation in Indonesia.
Well, the admitted one is the severe cases and moderate cases, but for the asymptomatic cases, they have quarantine or isolation in designated place. So like in Malaysia, but it's depend on each government. So each province have different situation and different policy. In Semarang especially, we have the housing of the mayor of the Semarang. They use it for the quarantine station for the asymptomatic patient. But so for the patient with severe cases and moderate cases, they admitted to the hospital.
So how do you get your asymptomatic cases?
They do the contact tracing. So if there is a patient, patient that positive, they show positive test for COVID-19, they do the contact tracing for the closest person around them. So the asymptomatic one go to the house of the mayor for the quarantine.
You know, I tried to understand about the situation in Indonesia. It's quite difficult because Indonesia is very big countries,
Yes.
and because of the different policies by the respective what do you call that? We call here states. Over there, I think you don't call it states, right? You call like
Province.
Surabaya, province.
Right.
Yeah.
Province,
So different province, different policies.
Yes.
So it's quite difficult for an outsiders to understand about the situation over there, you know. And then because the data that we witness from WHO or from the publications are actually in general for Indonesia, and of course it shows quite a bad situation, and we do understand because of the number of populations and because of the healthcare system as such that you had just switched from the, you know, now I mean although we can say that the national insurance schemes have been put place for more than 5 years, but it's still relatively young considered, yeah. And another thing that I would like to highlight here is that we understand now that other social determinants of health is very important, especially in Sabah, because Sabah as well as Sarawak, especially in Sabah because Sabah is very big, the demographic as well as the socio-economic status of the people over there is very much different from those in Peninsula, and we see many deaths now. It's close to 300 deaths. Okay, and almost 50% of the death occurred in Sabah, and those are among people who are with comorbidities. So that shows that although Malaysia has been proud of our healthcare system, but there is still inequity in terms of geographical, whereby in Sabah, many of the death occurred not only because of the comorbidity, but also occurs among young and those without comorbidity, and we feel that nutrition has a role in this. And another thing is that in Sabah there are so many undocumented people from Philippines. Okay, they stay in Sabah. They are so-called illegal, and maybe they are so afraid to come forward for testing. Okay, because we now practice mass screening in Sabah, so they are quite skeptical or quite afraid to come for testing because they might get caught. So usually they will only end up in our healthcare system when they are already severe, and when they have already disseminate the infection to many people. So this is where even Malaysia is not so big. Also, it's difficult for us to ensure equity. So what more is in Indonesia, which is so big with so many islands, yeah.
Yes. Okay, Nabila, do you have any more question?
No, I think it's enough. Thank you, Prof. Maznah, for the answer.
My pleasure. I think there was another hand.
Yes.
Up.
I think that was Inka that raised hand. Are you still going to ask questions? Inka. Yeah.
Yeah. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Professor Maznah. I want to ask you questions. So, as we can see, COVID-19 impacts economy globally. Besides, pandemic is still ongoing, and we all need costs for prevention or proactive intervention, such as PCR tests for screening and health treatment in hospital. In Malaysia, is there any policy or regulation from Malaysia government that cover up health treatment for COVID-19? Thank you, Professor Maznah.
Sorry, I didn't get your last question. Is there what in Malaysia?
Regulation or policy that Malaysia government do for cover up health treatment for Malaysian people that related to COVID-19?
Policy on?
Yes, like in Indonesia, health assurance from government.
Oh, I see.
Yes.
You mean the financial assistance with regards to getting treatment for COVID-19?
Yes.
Okay. COVID-19 is one of the notified disease. Okay. So because of that, it is free of charge for all, from screening, contact tracing until treatment. Okay. Similarly, if somebody having tuberculosis or having malaria, okay, it is one of also notified diseases, and because of that, there will not be any charge incurred, irrespective whether you are local or foreigners. So we do treat many of foreigners, especially those working in the industrial sectors, either from Bangladesh, from Myanmar, or even from Indonesia. Okay, they are in our hospitals, and when they are discharged, they don't have to pay anything.
Okay, thank you, Professor Maznah.
Okay, and admission is only to the public hospitals that has been gazetted as COVID-19. Like I mentioned just now, there are 147 big public hospitals in our country. Okay, but the one that is gazetted is only about 40. And of course, in Sabah, from 2 COVID-19 gazetted hospitals, now there are close to 15. Okay, even the small hospital had now been gazetted. And because many of the public hospitals are now treating COVID-19 cases, the army, okay, the Ministry of Defence, they had opened up temporary hospital to treat non-COVID cases. So we call this as Medan Rawatan. So cases from hospitals that are now treating COVID-19, those cases or those patients, they are transferred, or they are what do you call that, dipindahkan, to the Medan hospital, so that there'll be no mix of COVID and non-COVID patients in the hospital.
Okay, thank you, Professor Maznah. Well, I was interested when you said that there is a double cases in Sabah due to the election and also the political campaign. Well, in Indonesia, we're also facing that situation because the election is going to be on December, but now there's already political campaign everywhere in Indonesia. So, well, a lot of experts also said that we're expecting the rising cases of COVID-19 due to the political activity. And also this week, because this week is like national holiday, and we also have the cuti bersama. I don't know what is in English. So it's going to be holiday since Wednesday until Sunday, so it's really long weekend. So yeah, a lot of experts say that it's going to be a high rise of cases because people are, commuting from their cities to their home, their home because there's no local lockdown here in Indonesia. So
Yeah,
well,
that is clear in Malaysia. We are also going to have a long holiday from Wednesday, like you said, because of the Malido Rasul, right?
yes.
And because school is closed, and we also foresee that people will move from states to state. That is the reason why I'm also quite worried because they are going to continue because, like I said just now, myself and people in Selangor, Putrajaya, and Kuala Lumpur, we are under conditional lockdown. We think that it will be continued. So if it is under conditional lockdown, means that I cannot go to Penang, I cannot go to Kelantan, I cannot go to Johor. If I want to move about, I can only move about between KL, Putrajaya, and Selangor. So that is how they try to contain. And not only that, the government now asks every public as well as private companies to ask people to work from home. I'm supposed to work from home, but like I said just now, because I am considered as a frontliner and because I have to do surveillance here for my hospitals, so I can come to work. But otherwise, people cannot. You cannot move about, and there's only 2 person limited in a car. So if people wants to balik kampung, okay, they definitely they will bring their whole family and definitely will be more than 2 people, and they will be stopped at the border. Okay, and stop is okay. It's either you make a U-turn, but the worst thing is if they fine you. They fine is 1,000 ringgit Malaysia, which is about 3 juta rupiah. So that's quite a lot for ordinary people.
Yeah, okay.
What we are angry is that ordinary people, we don't reject, okay, no rejection, no demonstration, no what you call that, no resistance, but it's the politician, okay? They don't wear masks. Often we call the netizen, we will viral if we see people not wearing mask, face mask, okay? If we see the politician in a car more than 2 people, we will viral it. So in the end, is the people. Although the government is not taking any law or legal actions on the politicians, but it's the people who will punish them, okay, by put it viral in the social media. So
I think
it is definitely is going to be havoc after the election, okay. We had said so many times not to do the elections, but the government still went ahead in Sabah. And there's another election that's supposed to be in Sarawak. But this time the government listens to us, okay, because they now understand that what the people concerned is actually for the nation as a whole. So the election in Sarawak will be postponed till next year. But even if it's still going to go on, it will be via online. So no more campaigning from house to house.
Oh, well, that's great. Well, in Indonesia, the government is still going to hold the election on December. So the political campaign also, like what you said before, even though the people wear masks, but then the political campaign, they hold a musical concert with a lot of people. but after it went viral, then they get fined. But yes, there's still a lot of cases in a lot of province in Indonesia, because we have like the national election in December. So almost all of the province and also cities and district doing the election later in December. So yeah,
I'm so worried about that. Yeah, because what to do? So that's why I said leadership is very important. Strong leadership is very important. So if we cannot depend on the leaders of the country, then we have to take care or to take charge actions on our own. I think as a public health people, we should advise the people in the country so that they will wear facial masks and then keep social distance and frequent hand washing and whatnot, because in the end we have to take care of ourselves. We cannot rely totally on the government.
Yes, I agree with that. I think we have to, educate ourselves and other people around us, so we can prevent and take care of ourselves.
Yes.
Okay. Is there any more questions to Prof. Maznah? Okay, I saw Ajeng. You can unmute your speaker.
There's one question there.
Yeah, Ajeng.
Thank you for the presentation. My name is Ajeng Dianita. It has been explained previously about the technology strategy, namely the National COVID database system and apps for digital contact tracing. It's interesting for me because in the previous guest lecture, we got the same information about contact tracing in Australia in the same concept too, based on digital app tracing. Can you explain to us how this digital track application works in Malaysia? Thank you.
I think the principle of contact tracing is the same irrespective of what tool you use. It's just that by using digital is easier, because if let's say if I go to so everybody in their smartphone, okay, they have to upload or download these apps we call Maznah, okay. So this app, when we enter the premises, okay, we have to screen for the cannot see here for the code, yeah. So we have to use the apps for us to register ourselves, so that we don't have to type our name, our handphone number, and whatnot. Automatically, it will be collected by the CPRC. Okay, CPRC is the center who will collect all this data. So should there be anyone from the premises that we visited is positive COVID-19, okay, so they will look at the date and they use the code of that particular premise to trace who had been attended that place on that particular day. So then they will contact us because they have our phone number. Okay. Yes, sometimes people forget to bring their handphone, or sometimes people they don't have the apps, they don't have a smartphone, so they can just write their names in the book. Every shop or every premises, they will have a book for you to sign in, or they will display the code of that premise for you to use your Maznah, and then they will scan your temperature, and they usually put a hand sanitizer at the entrance, so you just have to take the liquid and then sanitize your hand. Then only they will let you in. And usually at every premise, there only one entrance and one exit. You know, like before, we can enter a supermarket from various entrance, right? But now there's only one entrance. I mean, of course, it is quite troublesome, okay? Especially when you enter a mall, there are so many outlets there. So each outlet that you want to enter, sometimes we just want to see. We don't want to buy. We just want to see. You still have to register. So that is why not many people likes to go for shopping, okay? But the government now allow us allow the premises to open because they don't want their business to be, they need their income. Okay, and the government encouraged for us to do shopping via online. Okay, did I answer you?
So basically, this app trusts us for based on the code, right?
Yes.
Because in Australia before we know that they use Bluetooth for this app tracing,
Yeah, the code. Yeah, because we have when we check in, our code match with their. I mean, we will capture their code in order for us to get into the registration, and then after that, our code will be detected by their machine. Sorry, not their machine. Their code will be in our handphone. Okay, and this code will be collected by the CPRC, like I mentioned just now. So CPRC can just click on the code of that particular premise, and then on that particular day, they will see our names in their system.
Okay, thank you. This is similar in Indonesia.
Yeah. So there are instances where several times we were called. Okay, I received a call from CPRC. CPRC is like I said just now, the Center for Emergency Disaster Management. So Communicable Disaster Management Center, whereby they are the one who will contact us as part of their contact tracing. So it'd be easier for them if they have our phone number. They don't have, if it is manual, it takes ages for them to contact the people who has been to that particular place. And the home quarantine is very strict. My son came back from France. Okay, he was home quarantine that time. Home quarantine still. Of course, if he comes back now, he will be quarantined in the hotel for 2 weeks before he can come home. But when my son came back, at the moment he reached the airport, he was tested. Okay, they use they use antigen test, so it was ready in 2 hours. So once he's negative, he's allowed to come home. He will be he was given a bangle, a pink color, okay, stating that he is supposed to be home quarantine. So from the airport, he has to reach home directly. He cannot stop anywhere, because if the people see him wearing the bangle, the people will call the police, or they will viral it, okay, saying that this person is supposed to be home quarantine, but this person is mingle around in the public. So he came directly. Okay, at day 5, the health personnel, the public health personnel, okay, they came to the house and to spot check whether he is around at home. Okay, and then he has to go to the nearby clinic, public health clinic, for him to be swabbed, second swab. So that is in day 5. So at day 13, if it's negative, he will continue to stay at home. And at day 13, okay, he's supposed to go again for the third swab. Okay, this time they use PCR. So in the next 24 hours, he was informed that he's negative, and because of that, he was released from home quarantine. So he has to go to the clinic and remove his bangle. Okay, I know it's troublesome because he has to go to the clinic twice, at day 5 as well as at day 13. But people complain, but they still do. Okay, they still follow.
Okay, Ajeng, how about it? Do you have any more?
No, thanks for the answer. Thank you.
Okay, well, it's really strict about the home quarantine in Malaysia. Well, in Indonesia, even though you are told to stay at home, not all of the people, obey the rules. Okay, we have another question from Pak Septo. He is also one of the lecturers in Health Policy and Administration. He's asking, what is the local wisdom of Malaysian that could support the COVID-19 pandemic treatment efforts and policy by the government. Because we have a local wisdom here in Central Java called Joko Tonggo. So it's like taking care of your neighbor, jaga tetangga. So it's like if you have any cases in your neighborhood, you will and they have to do the home quarantine. The people around the neighborhood will, provide meals for you and also provide the support for the family that affected by the pandemic. So, is there any similar situation in Malaysia or how?
Yes, definitely. Like I mentioned just now, NGOs. There's so many NGOs. But even without the NGOs, the government usually will not only provide financial assistance but also provide food. For example, in one situation, the foreign workers from Myanmar, okay, they stayed in these hostels and they were quarantined. They were on total lockdown. This is what we call CMCO, because other areas are free from COVID-19, but this particular area, okay, there was COVID-19 positive, and because of that, the whole blocks of hostels where these foreign workers stayed had been under lockdown. So the government sent food to them. Okay, they don't have to do anything. They don't even have to go for shopping. Shopping means they don't have to go and buy groceries because they don't have to even cook. Foods are provided to them. Okay, breakfast, lunch, and dinner. All right. This contradicts to, I think, one of the there was once viral in social media pertaining to they are not given food. It's not right, actually. They were all given food, and even for the Malaysia, okay, when there is a lockdown in certain places, okay, the NGO will hurriedly come and provide food to them.
Okay. Pak Septo, do you have any more thing to add? Maybe you can unmute your microphone.
Okay, I think it's enough, Dinar. Yeah.
Okay.
But I have to say, what we do in Peninsula is much better than what's happening in Sabah. And again, like I said just now, because Sabah, the country is so huge, and people are in places where it is very difficult for us to get access to. No transport. We have to go through the river, okay, or through helicopter. So these are the people that we are so worried. Or maybe they don't have cases there because they're quite isolated, so we don't really know. Okay, but for sure, those people at the coastal areas, especially those undocumented people, okay, even though they are non-Malaysians, okay, they also get access to treatment, get access to food, and of course not financial, but at least they are given food. There are so many NGOs who are now in Sabah, and the situation there is as such that many of the doctors, many of the nurses are now being deployed from Peninsula to Sabah.
Okay. But it's provided from the NGO, right? Not from the community itself. I think not from the people.
Yes, from the people as well.
Yeah. Okay. Okay, thank you. So I think that answered the Pak Septo questions. Any more questions from the attendee? Hello? Do you have any other question? Okay, if not, then I think I'm gonna ask one more question. According to your presentation before, that the Malaysia also spent a huge money for the COVID-19 situation, for the quarantine, also for the treatment. And is it, I think in government stuff in here, we have a lot of program that has to be delayed due to the refocusing for the budget. So like if there is a budget for maternal and health program and it has to be delayed because the money have to be transferred for the COVID-19 handling. So is it also happen in Malaysia, or?
Yeah, actually, I think I did mention about the budget that was supposed to be a new program for NCD. Okay, that was allocated for 2020 for NCD, that has been used up. Again, it is not used up just by COVID itself, but also of the program. But otherwise, the normal programs, okay, the budget that has been allocated to them are not being touched. Okay, it's just that for NCD, because of the situation of NCD, which is like triple or four times than before. So the government last year had allocated a special 5 billion for NCD. Okay, so that special 5 billion has been touched, okay, and given for COVID-19. But otherwise, the normal program or normal activities for NCDs, as well as maternal and child health and other primary healthcare programs, they are still continuing. Maybe I think what I did not presented just now is how much the government had to pay the private hospitals, because they are now taking care of, not now, I mean last time during March and April, they took care of non-COVID cases. So the private, let's say for example, usually if they charge for appendectomy, if they normally charge 10,000 ringgit Malaysia, but because of COVID-19, okay, they take patients from the private from the public hospital, and they charge nominal fee, just like when the government is supposed to charge, maybe about 3,000 or 4,000 ringgit Malaysia. And so this is one of the social contribution by the private sectors. They took care of the public patients from the public hospitals. They continue with their private practice, but at the same time, they also look into the patients from the public hospitals. So that cost incurred for treating these public patients will be paid by the government. I have not included that in all the budget that I've spoken about for Ministry of Health.
Okay, I think that was different in Indonesia, because well, a lot of normal program that have to be run normally, but it's being delayed because there's no budget for it, because the budget is allocated for the COVID-19 situation. And also for the private sector, I think the government only pay for the private hospital only for the designated hospital. So if the hospital is not designated for the COVID-19 patient, the patient have to pay by themselves.
I see.
So yeah, I think that's the difference here. Yeah, because the high cases and also the public hospital is not enough anymore for the patients.
So for us, all notified diseases are to be treated by public hospitals. So the private, they don't treat COVID-19.
Okay.
Yeah. And except for my hospital is University Malaya Medical Center. Okay, we are included as one of the gazetted hospitals. So because of that, when the patient COVID-19 comes to us, we don't charge, because that is our social contribution to the government. Otherwise, usually, although we are university hospital, when patient comes for operation in our hospital, they will be charged more than if they are to be charged at the public hospital. Because in Malaysia, there are many type of hospitals that belongs to the government. One is Ministry of Health hospitals. Second is university hospitals, or under Ministry of Education, and third is under Ministry of Defence. So these are the three places considered as public hospitals, but only Ministry of Health not charging the public. My university, we do charge the public, but at very low cost. So compared to the private, of course, we are like 10 times cheaper than them. And as for Ministry of Defence hospitals, they are actually for the army and their family.
Okay.
Yeah. So if you are having COVID-19, irrespective whether you are local or you are international, don't worry. Okay, if you go to the hospital, you will be treated as the same like the Malaysian. No need to pay.
Okay. 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 Any more questions for Professor Maznah? We still have like 20 or 25 minutes left until 12. Hello. Maybe we can have like 1 or 2 more questions from the students or other lecturers. I saw Bu Eka or Bu Bulan, Pak Zen. Maybe you have any question?
Can I ask a question?
Yeah, sure.
This is pertaining to vaccine. I understand that Indonesia is developing your own vaccine, right?
Yes.
So what is the progress like?
Well, still on the clinical trial. It's conducted in Bandung for the massive people. There is still, we still haven't get the progress after the clinical trial, but they're already testing to the people, like 1,000 people, something for the vaccine. But well, the government already, issue a policy that after the vaccine is ready, it will be priorities for the health workers and also people that working in public sector. But well, in Indonesia, vaccines is always there's always like community that reject vaccination. Even though it's the basic vaccination, there's still community that reject it. So yeah, for the COVID-19 vaccine, there's also some people that still reject or doubt about the vaccine, especially because it's from China. Yeah, there's a lot of misinformation spreading in the community.
Yeah.
So we're still not sure when the vaccine will be ready.
So the vaccine will be covered by BPJS?
I think it will be covered by the Ministry of Health. Actually, in COVID-19 patients, it was not covered by the BPJS. So the fund was from the Ministry of Health. So it's different from BPJS.
I see.
So the BPJS only for the other cases, but not COVID-19.
Mm-hmm. Okay, thank you.
Yes, it's quite confusing in Indonesia because the policy keep changing, and we have a lot of misinformation spreading around. Any more question? I think I saw someone that unmute their microphone, but it's not here anymore. Hello? Any question? If not, maybe we can end this guest lecture. Professor Maznah, can we have your presentation, the slide?
PowerPoint, you mean?
Yeah, PowerPoint.
Okay, I will email to you.
Okay, thank you very much. Because there's a few people that text me that asking whether if we can get your slide. Okay, so I think there's enough. No more question. Really? Because we have this guest lecture like just once a year, so I think this is a perfect situation for you guys to ask to Prof. Maznah. And don't worry if you are not confident with your English, you can just ask in Indonesia. Prof. Maznah will understand your question. No?
Yes, I can, because I am, my father is from Bukit Tinggi, Indonesia.
Oh, okay.
So I can speak Indonesia, but I cannot speak Minang. Don't ask me to speak Minang or Java.
Yeah, I think it's similar, the bahasa between Indonesia and Malaysia. I think just different in few vocabulary.
Bahasa Indonesia lebih enak. Lebih enak didengar.
Oke, ada yang mau nanya? Silahkan dalam bahasa Indonesia pun nggak apa-apa. Cukup yang semester 5, semester 7, semester 9. Mungkin yang penelitian tentang COVID juga. We have a lot of students that doing their final project research about the COVID-19 situation.
Oh, that's good.
So yeah, because they are prohibited from doing the research in hospital for the safety reason. So they have doing the research around their area about the COVID-19 situation, about the policy.
That's good. Yeah. I think there are more and more publications pertaining to COVID-19 which you all can read.
Yeah, because it's a really hot issue right now. So
I think this is where you all can emphasize on universal health coverage and SDG to relate it with COVID-19 because this is under health policy and management, right?
yes.
So actually, for us, public health usually is like it's not considered as important for the clinical. So when COVID-19 occurs in Malaysia, the public health field is now getting more popular, and more public health specialists are being invited to deliver a lecture or even talk in the media. But otherwise, before this, people don't really understand what is the role of public health. Now, many people we can see that they appreciate and they understand what public health is.
Yes.
Unfortunately, with regards to talking about the interventions that is to be put in place with regards to COVID-19, is only the DG himself can talk. Nobody else can talk. Okay, so we were wondering why, because usually the DG will be accompanied by 4 deputy Gs, and the 3 of the deputy Gs are actually from public health, but they never speak. They just stood still besides the DG. So by right, things like this is very technical. It should be given to the public health people to talk about rather than non-public health people.
I think it's similar in here. The Ministry of Health also did not speak a lot about the COVID-19. So most of the people that speak is from the juru bicara. So it's like, but he's an epidemiologist from University of Indonesia. So yeah, he is a public health specialist. But well, people are wondering why our Ministry of Health are keep on silent, and even in social media there is some news that say that our Ministry of Health is missing in action because we don't hear a lot from him about the COVID-19 situation, even though it's supposed to be from the Ministry of Health. I'm also
ours is from Ministry of Health, but it's just that within Ministry of Health there is bahagian perubatan, bahagian kesihatan awam.
Yeah.
Okay? So it should be that the bahagian kesihatan awam is the one that is delivering the message to the people, because as much as people are following, people are actually getting fatigued, sudah bosan, agak bosan and the situation. So we need experts, especially with regards to behavioral, with regards to how to communicate effectively with the people, so that people will continue to follow the SOP of COVID-19. That's why I think like in America or even in United Kingdom, the resistance there is very high. So that's why it makes the situation worse. So if you study why the cases are more in certain countries, there are so many factors. Okay, so there are things that we can we as public health people or public health community can take charge or can take control. Okay, but of course there are other things like for example the financial and whatnot, that we have to rely on the government for them to help the people.
Yeah, well, in Indonesia we have like gugus tugas. So in each region they have like called gugus tugas, like a task force team. It consists from the public health people. So, but it's only working in their area. But we also have the national gugus tugas that also led by the public health specialist. But well, it back again with the behavior of the people. Yeah, we cannot push or make sure that everyone will follow up the SOP or the protocol, but we are trying, and especially because there's still a lot of people that think that COVID-19 is a hoax and a conspiration, so they don't believe that this is a really dangerous situation it happened in Indonesia. And if I was asking for your opinion, which country do you think is the best on handling the COVID-19 situation?
Actually, there are many good countries. There are countries who are able to control, but then it's again versus time. Like for example, in the early during the early pandemic, for example, Korea, Taiwan, even Japan. Okay, they were good. Okay, in controlling the cases. Okay, but then after sometimes people may get people may become lax, okay, and the government may see that they need to focus on economic, okay, so the cases could come back. Similar like in Malaysia, everything was okay from the month of June until September. That's why when we told the government not to do the election, they say that, oh, okay, so far we have been good, so it's okay for us to continue. We will follow the SOP, but looks what happening. So a country may be good in controlling or containing the COVID-19, okay, at one time, but at other time it can be worse. Just like New Zealand also, at one time it was very good. It was considered as the best country in controlling or containing COVID-19, but now cases started to occur again, okay, because they open up their border to allow people from outside to come in. So don't know until when the situation will be better. Let's hope and let's pray that 2021 will be a good year for all of us.
Yeah, I think it's well, in Indonesia also, when the first cases came out around March, the people are strictly stay at home, but then as you mentioned before, people start to getting bored and bosan, and because they have to stay at home and they cannot do working outside again, so that's why the case started rising when the people going outside. And also the government once opened the border for the tourism area, because a lot of tourism industry are affected by the COVID-19, so the government opened up for the tourism spot, and that's when the cases start rising again. I think it's because like what you said before, we don't know how the situation will be like this until when. Okay.
Then again, like I said just now about the vaccine promise, okay, I think people have been putting a lot of hope on vaccine, but they have to remember that no government could afford to vaccinate all their people. Even to reach for herd immunity, I think more than 60% of the people needs to be immunized. So imagine if in Indonesia 60% of the people need to be vaccinated, there is more than 150 million, right?
Million. Yeah.
So, and that is very expensive.
Yes, and nobody can make sure that the vaccine is working properly.
Yes.
Because
and in Malaysia, if you must know that we have a new strain that arises from Sabah outbreak, and this strain apparently come from Philippines. So Now, if we are to buy vaccine, we don't know which strain we want to buy because we don't know what is the strain prevalence in among the people. So it's very difficult, and even people say also the vaccine can last for only 3 months, you know. So this is really a big dugaan from Allah Subhanahu Wa Taala. So all of us, we have to pray hard.
Yeah, and the best prevention is, you know, taking care of ourselves, like
Yes.
washing hands and stay from the people and stuff. Okay, is there one more question? No, we have still like 5 more minutes. If not, then maybe I can conclude from today's guest lecture. So based on our discussion and also presentation from Professor Maznah Dahlui, we can conclude that COVID-19 strongly impact the economic situation in all countries, not only in Indonesia, but also in Malaysia, because the government need to spend a huge amount of money for handling the patients, quarantine costs, and also the healthcare facilities and stuff, and other costs. And especially in Indonesia, government also, provide like social aid for the people that affected by the COVID-19 economically. So they like give like a few hundred thousand rupiahs for the low economic people for helping them surviving this COVID-19 situation. And also, what's different in both countries is the behavior of the people. We see that we cannot compare it directly, but because Indonesia has a lot of population, and also we have like a lot of island, and the area is also really big, so we cannot compare it directly. But Malaysian people show like a less rejection about the health protocol, and they show like they obey the rule that provided by the government. It's kind of different in Indonesia. But yeah, we don't know until when this situation is going to be continue like this, and we hope everyone can survive this year, and next year will be a better year, I hope, from 2020. And back again, the best prevention is washing hands, stay from crowd, and stay at home if you can, and also please prevent yourself from spreading, even though if you are asymptomatic and you have no signs of the COVID-19, but there is also a possibility that you have the virus. So please take care of yourself, and I hope we can meet again, Professor Maznah, and maybe you can come join the guest lecture live offline in Semarang maybe someday.
Inshallah.
I hope you can visit us, our university. I don't know, after the COVID, of course. And I hope, like what the dean said in the opening, I hope we can continue the collaboration, not only for the guest lecture, but maybe for other stuff like collaboration research or something. I hope we can continue this collaboration, especially because we are from the Health Policy and Administration Unit. It's the same like your specialist. And thank you for everyone that attending this session. Thank you for the students, lecturers, colleagues, and also the committee for conducting this event. Thank you also for Professor Maznah for attending this event and for agreeing, talking like 2 hours for us in University Ponorogo, even though it's online. I hope we can meet again in the future in a better condition. I'm sorry for if there is any mistakes from me or from the committee. Thank you, everyone. Assalamualaikum warahmatullahi wabarakatuh. Do you want to take pictures together, Professor Maznah? Is it okay? Okay, I think maybe we can turn on our camera, some of the students and the committee or the lecturers.
Everybody's shy.
It's okay. Just turn on your camera. The students also allowed, or are you not? Even though you're not taking bath yet, it's okay. because we held most of the activity online, like the courses, even though the practicum for the laboratory, there's also online, like using the videos and stuff. So yeah, it's kind of hard for the students also. We call it the students in COVID generation. Because they do this research online, also community participation also online. No, nobody wants to turn on your camera. Oh, good. That's fine then. Let's just take the picture. Wait. Okay. Thank you again, Professor Maznah. I'm sorry if there is. Yeah, bye. Thank you. I hope you stay healthy and